Go ahead and get started. I know there's going to be more trickling in. Oh, he is in the booth. We'd like to welcome Dr. Charles Phan today from Sugar Land, Texas. Dr. Phan is assistant clinical professor of surgery, medicine? Medicine at Baylor College of Medicine. Was with the abdominal transplant program there, but now is in private practice and again in Sugar Land. Gastroenterology. He did his medical training at the Medical College of Wisconsin and did his internal medicine and gastroenterology at UC Irvine. Is a California native. Southern California. Do we have any other California natives here? And today he's going to talk to us about chronic hepatitis B, current issues, treatments, and cure.
Thank you. Thank you very much for the introduction. It's really a pleasure for me to be here today to share with you some information, a little bit about hepatitis B, and try to address whether or not we can cure hepatitis B. So I'm going to try and kickstart your day. How many of you have seen this article in the Time magazines a few years back, right? This is about Tiger Mom. So we usually do our hepatitis B awareness a lot around the city, and one 11-year-old came to our awareness event and heard about Hep B, came home, found his mom in the kitchen doing dishes, and he came to his mom and pulled on her shirt and said, "Mom, I think I have hepatitis B." And his mom immediately dropped the dishes and turns around and said, "What? Why not A?" That's a little bit humor, hepatitis B in Asian community, but really hepatitis B is a global disease, not just in Asian community. And I want to emphasize, especially in the African American community, immigrants from Africa, the rate is quite high there too. So I'm going to talk a little bit about epidemiology, transmission, and discuss a little bit about virology, screening tests, and go discuss natural history, and try to address whether a cure is possible with hepatitis B. So worldwide, there's about 2 billion people have been infected with this virus, and currently about 240 million people have chronic hepatitis B. And it is a leading cause of liver cancer worldwide. And it causes 80% of all liver cancer in Asian. More than half of the liver cancer in the world is from China. So that's where the rate is highest. The issue with Hep B is that it's a little bit different than Hep C, where you have liver cancer in Hep C in your patient who have cirrhosis already. With hepatitis B, up to 50% of the time it occurs in the absence of cirrhosis. And it is much more infectious than HIV. So this is the map of the world showing us all the different geographical areas in which the prevalence rate are high in the areas here in Asia and Southeast Asia and Africa. So these are more than 8% of the populations have chronic hepatitis B. And the areas in the darker gray, which includes Eastern Europe, South Asia, the Middle East, are the so-called intermediate prevalence area. That means 2 to 7% of the populations have chronic hepatitis B. And in the US or Australia, for example, we're supposed to be the low prevalence area. That means 2% of the populations have chronic hepatitis B. Now, the problem is that due to immigration pattern, people bring the disease with them to their community. So 90% of foreign-born person with chronic hepatitis B came from an area of these gray or red area. So that's almost 3/4 of the people in the world are the ones with chronic hepatitis B coming into the US. So if we look at, of all the hepatitis B patients, about 5% or so come from Eastern Europe, and of course, up to 62% of those patients are from Asia. And from South Asia and the Middle East, 13.5%, but also from Africa is going to be about 14.1%. So these rates also can be seen in the ethnic communities all around Houston. We do see a lot of African Americans from Africa having chronic hepatitis B in my practice in Houston. So here, looking at the ethnicity CDC data, majority of the patients, of course, are Asian Pacific Islanders, but 9.1% are African American, and these are African American immigrants from Africa, not the ones that are born here in the US. And the death rate from this group is majority, the death rate related to hepatitis B is in the Asian American, Pacific Islander group, but also in the African American from Africa. You know, I always tell the story how I have a patient from Nigeria who's only 22 with massive infiltration liver cancer. And there's not much we can do for him at that point, but he's only 22. And that's what you see in the African American community from Africa. So the problem is that people who have hepatitis B, up to a quarter of them will die of Hep B-related liver disease, and the majority of the time is related to liver cancer. So 2 out of 3 persons who are infected with hepatitis B are unaware that they have hepatitis B. And so they can unknowingly transmit the disease or present only at a very late phase. So what we need to do is we need to identify those who needs treatment, and hopefully we can stop the disease and prevent some of the complications. Not everyone will need treatment. So one of the most common questions I always get is, why does Asian American have so much hepatitis B compared to other ethnic groups? And that's because in the areas in which there's high prevalence, the most common mode of transmission is vertical transmission. That is through the infected mother transmitting the disease to her child as she's giving birth to the infant. And the age at which you come in contact with the disease sort of determine the outcome of chronicity. So the younger you are when you contract the disease, the higher the likelihood of progression to chronic disease. So in Asian countries, if that child is infected with hepatitis B through his mother, 90% chance that that person will have chronic hepatitis B. Now, the same mother come to the US, give birth to the child, that child now have only a 10% chance of getting chronic hepatitis B because we now give HBIG to infected mother and also vaccinate the child. With that, we can reduce the transmission rate down to 10%. Now, in the US, more commonly is through sexual contact and drug use. And so as an adult, when you contract the disease, only 5% go on to develop chronic hepatitis B. So, so most patients who have hepatitis B, who are Asians in your practice, will be the one who got the disease for many years. And they probably got it from as a child or very young age. So hepatitis B is a DNA virus. It is a highly replicative virus, up to 10 to the 13 billion per day. And it's not the Hep B virus that causes the damage to the liver. It is our immune system recognize the virus and mount an immune response, leading to inflammation, fibrosis, and then liver cancer. Now, the virus remain in our body through, when it enters the liver cells, the cccDNA is the genome template for viral replications, remains in the nucleus. And so that's one of the way it remains persistently infected in our liver cells and persistently for years is the cccDNA remains in the nucleus, and all of our treatment does not affect the cccDNA. We only affect the replicative form of this virus. So here is the serologic markers of hepatitis B. So it is a double layer virus. The DNA is in the middle, is inside capsid protein, and outside of that is the surface membrane. On the surface membrane is the surface antigen. So the surface antigen is a marker of chronic infection or acute infection. So you have surface antigen, you have Hep B in the body. And surface antibody is a marker of immunity. So it can be induced by vaccination or a prior infection. And the core antibody is actually a test of exposure. So if you've been exposed to hepatitis B, your core antibody total will be positive. And core total includes IgM and IgG. So if you suspect that the patient have an acute infection, you would check an IgM, then the patients have an acute infection. But the core total, then, if you have core positive, you have been exposed to hepatitis B. HBV DNA is a measure of viral replication. It is also a marker of infectivity and a predictor of progression of liver disease. We'll show you a little bit of that data in a little bit. And E antigen used to be a marker of infectivity before the days HBV DNA was available. But now we no longer use that for that purpose, but we still can't use it to categorize hepatitis B. So in people who have hepatitis B, there's two types, E antigen positive disease, hepatitis B, and E antigen negative disease. And we'll show you a little bit about the natural history slides so you get a better idea about those differentiation. So here is some example of screening tests. I actually recommend all three if you can screen your patient for hepatitis B: the surface antigen, surface antibody, and core antibody total. So this first scenario, this patient have surface antigen positive, so this person have Hep B, antibodies negative, so he's not immune, but core positive, so this person's been exposed to Hep B. So this person can either have acute or chronic Hep B. So if you suspect that they have acute Hep B, then you would check an IgM, and that will confirm that they have acute chronic hepatitis B, chronic Hep B. So this next scenario, surface antigen is negative. This person does not have Hep B. Surface antibody is positive, so they're immune, and core antibody is positive, and they've been exposed. So this person is immune to hepatitis B through a prior exposure. This next case, this person's surface antigen is negative. They don't have Hep B, but surface antibody is positive, so they're immune. But core antibody total is negative, so they're not exposed. So they are immune through a prior vaccination. And this last case, they remain susceptible, so then they need to be vaccinated because they're negative for all three tests. Now, this is the latest recommendation for screening from three different societies: the American Association for the Study of Liver Disease, the CDC, and the U.S. Preventive Services Task Force. Anyone from an area of a prevalence rate of 2% or more, remember that map I showed you, the dark gray area and the red area? Anyone from that area, we ought to screen them for hepatitis B. Certainly, US-born patients who have not been vaccinated and their parents came from an area of high prevalence, they ought to be screened also. And it's currently part of the workup for abnormal liver tests. All pregnant women are being screened. People with alternative lifestyle, drug abusers, and HIV patients ought to be screened. And this is some of the new recommendations. People needing immunosuppressive therapy ought to be screened, because we now see patients receiving chemotherapy with immunosuppression, especially lymphoma, et cetera. They have reactivation of their disease. So that's the recommendation now, that we need to screen those patients before starting chemotherapy. Now, one of the most common reasons that people cite for not screening is that your patient reports that they've been vaccinated already. So this study is from Korean patients who report they've been vaccinated. And actually, only about 60% of those patients reported they are vaccinated in the past actually are immune from vaccination. 26% of them had a natural infection. They're immune to a natural infection, so the vaccination was not needed in that case. Almost 11% remain susceptible to the infection. And what's interesting here is that 2% of those patients have chronic hepatitis B. So despite the fact that your patient comes in and tells you they've been vaccinated, we still need to screen them at least once. And it's the most common reason for, at least in the primary care setting, to cite that they don't screen patients because the patient told them they've been vaccinated already. So what happens if patients have hepatitis B and we don't treat them? So this is a systematic review a few years back looking at people who have chronic hepatitis, and if we don't treat them, what happened? Well, up to 17 to 38%, 17% E antigen positive, up to 38% E antigen negative, may progress to cirrhosis at the end of 5 years. And if you have chronic active hepatitis, you can develop liver cancer, 1 to 3% at the end of 5 years. Even in the patients who are carrier, they're supposed to have a better prognosis. They may also have liver cancer up to 1% at 5 years. Once you reach cirrhosis, up to 10 to 17% may develop liver cancer in 5 years. And then about 14 to 15% may have a liver-related death after you reach cirrhosis. And then decompensation is about 15%. Once you decompensate, the majority of the patient will end up with a liver-related death unless we transplant them or we do something about their disease. But these are systematic reviews from different areas in the world. What happened to patients in the US who are not treated? So this is a Kaiser Permanente cohort study from 1996 to 2005. They have a group of patients with chronic hepatitis B, and they do not treat that group of patients for the period of 10 years. So they have over 3,400 men, over 3,200 women. What they found is that the 10-year death rate in men was up to 8.9%. The 10-year death rate in women was 4.1%. 4.8% of that in men is related to HBV. 1.2% in women was related to HBV, but what they found is that those who have HBV-related death, up to 40% of them occur after age 40. And the most common cause of death was going to be liver cancer. And so In terms of HBV-related death, it's twice as common due to liver cancer rather than hepatic decompensation. So the risks seem to increase much more in men after age 40 and women after age 50. And the lifetime risk of dying from an HBV-related cause for a person who had chronic hep B was found to be on average, about 42%. So now that we understand a little bit about what happens when we don't treat patients and who we should screen, now we need to identify who should be treated. But before you treat the patient, we need to take into account the likelihood of complications if we don't treat the patient and the activity of the liver disease at the time of treatment, and estimate the risk of liver cancer or cirrhosis in that patient, and understand the natural history of hepatitis B and the benefits of therapy, the limitations of therapy. And we want to balance that with the patient's preference, the age, and we take into account the family history of liver cancer. A patient with hep B who have a first-degree relative with liver cancer are at a much higher risk of liver cancer than a person with hep B without a family history. And so, of course, we balance that with the drug side effect, et cetera. Drug resistance is quite low with the current treatment. And here are the parameters that we use to identify who should be treated. ALT, we want to use the new ALT criteria, which is for men is going to be 30, for women is going to be 19. And HBV DNA actually predicts the rate of progression to cirrhosis and liver cancer. And in cases where we cannot decide whether or not we should treat them, but we think they ought to be treated, but they don't meet the criteria for treatment, then we resort to a liver biopsy or a non-invasive approach to assess fibrosis to help us in the decision whether or not the patient should be treated. So this is an older study in 2006 from Taiwan. They have over 23,000 patients enrolled in the study, and in their cirrhosis analysis, over 3,500 patients, over 3,600 in the liver cancer analysis. They followed the patient for about 12 years, and what they found is at the end of follow-up, 10% of the patients or so have cirrhosis, about 4.5% develop liver cancer. So what they try to do is they try to figure out what is the one key factor that we can identify in managing these patients and predict who will get liver disease and who will have liver cancer. It turns out it is the baseline HBV DNA is a predictor for cirrhosis and liver cancer. We're starting here above 10 to the 4th copies, or more than 2,000 IU, we start seeing an increase in the risk of, for progression to cirrhosis in e-antigen negative disease, and a similar relationship can be seen in e-antigen positive disease. And also, the same relationship in terms of liver cancer. This blue line here is the baseline viral load of more than 10,000 copies, or 2,000 IU. We start seeing an increase above that, and if there are over millions, the rate increased dramatically. So the higher the viral load at baseline, the higher the likelihood that this patient in the future might have cirrhosis and liver cancer. So HBV DNA is one of the key factors that we use to determine who should be treated, who should not be treated. Now, in terms of our current antiviral therapies, over the years we have interferon, lamivudine, which we no longer use lamivudine due to a high resistance rate, up to 25% resistant after 1 year of therapy. These down here are going to be the current treatments for hep B in terms of oral agents, and we now have a new player, tenofovir alafenamide, which is a new prodrug with lower dose and better side effect profile. So the first line, so when we treat patients, there's endpoint therapy. That means those are mainly oral agents. We treat them until we meet the endpoint, and then we consider stopping the therapy. And there's finite therapy, that is with interferon injections. We would inject them once a week with pegylated interferon for 48 weeks, and we stop. Response oftentimes lags behind even after we stop the interferon injection. But interferon have a lot of side effects. We can't give them in pregnant women. They may exacerbate hepatitis B. You can't give them in people with autoimmune hepatitis, et cetera. So we got to be careful about all those groups. And because of the side effect, I usually reserve them for young patients who does not want to take medication or who want to be pregnant. Maybe we can consider finite therapy. Otherwise, due to better side effect profile and efficacy, oral antiviral agent is what we usually use in our older patients. Now, the goals of therapy with hepatitis B is to normalize ALT, suppress viral replication, and with that, we can hopefully lead to the loss of e-antigen in those who have e-antigen positivity, and has been shown that with that, we can improve the histology. Cirrhosis actually regress after 5 years, 3 to 5 years of therapy. Fibrosis also regress. And we may also affect the risk of liver cancer. So up to 50 to 80% reduction in the risk of liver cancer if the patient needed treatment and they were treated. So here is the slide I was talking about the natural history of hepatitis B. And this is one that you want to commit to memory to help you decide who should be treated, who should not be treated. So when the patient first got transmitted with the disease, they often have e antigen positivity. And these patients are your typical young Asian patient, 20 to 30-year-old patients who contract the disease as a child. So these patients have normal ALT, but very high viral load, and e antigen positive. High viral load, more than 10 to the 7 copies, so several 100 million copies. Normal ALT is the norm. So these people actually have good prognosis, short-term prognosis, but some of them may have a little bit more aggressive disease, especially if they're older, but for the most part, they have good prognosis. So those patients do not need treatment. But for some reason, after 20 or 30 years, after 30 or 40 years into the disease, the immune system starts to recognize the virus and mount an immune response. So here, we call this the immune clearance phase. That's when you see HBV DNA is elevated, but the liver tests are also persistently elevated. So the longer, the amount of time you spend in this phase, the longer time you spend in this phase, the higher the likelihood of progression to advanced disease, the higher the likelihood of fibrosis and inflammation. If the immune system is able to suppress the virus, we enter into the low replicative phase, or the so-called inactive carrier phase. But this phase, the DNA is low, oftentimes undetectable, or less than 2,000 IU, but ALT is persistently normal. The key word is persistent. Every time you check them, they're always normal. Okay? But up to 30% of the time, when you first see a patient, you categorize them as an inactive carrier or low replicative phase, they are actually in what we call reactivation, deactivation, or e antigen negative chronic hepatitis B. They're in this phase. And once the immune system is able to suppress the virus, we seroconvert, we become e antigen negative, but up to 30% of patients who are inactive carrier actually have fluctuating viral replications. So they have intermittent elevations in the ALT and intermittent elevation in HBV DNA. So these people also have inflammation, they're just intermittent. Okay? So oftentimes these are the older patients because they have the disease for many years and it's after seroconversion. So who do we treat? We treat the people who have active inflammations with abnormal liver tests and high viral load. So if we can identify these patients, we treat this group and we definitely treat that group of patients. These patients do not need treatment. So this is a useful framework of when you evaluate your patient, try to categorize them, and then we can decide who should be treated and who should not. Now, some of the difficulty in managing patient with hepatitis B is differentiating e antigen negative disease from inactive carrier. So the key thing here is that we have to evaluate the patient frequently enough to see that we pick up the elevations in HBV DNA and ALT. So here I've listed some of the characteristics. E antigen negative disease, they have fluctuating HBV DNA, fluctuating ALT. They may be normal one time and the next time they're elevated. Okay? As opposed to inactive carrier, they're persistently normal, oftentimes negative. And also ALTs is normal. But here, the basal core promoter mutation or pre-core promoter mutation are usually seen in people who have e antigen negative disease. So if your patients have elevation in ALT or intermittent elevations, if you check the pre-core promoter and they're positive for that, then you're suspicious that this patient may be the one that will be the e antigen negative disease, but we just haven't picked it up yet. So the key word here is serial labs monitoring. So we usually, when we first evaluate patient, we at least check them every 3 months for 1 year so we can get the gist of how their disease is behaving. So we would need to check them that frequently, and then we move to every 6 months if they remain stable. Now, in terms of the significance of pre-core and basal core promoter mutation, most patients with e antigen negative chronic hepatitis B have mutation in these two areas, and it is associated with an increased risk of liver cancer, and pre-core mutations are associated with fluctuations in ALT. And so that's one of the ways that you can pick up that these patients are the one going to be the one having e antigen negative disease. So here is the treatment guidelines from the American Association for the Study of Liver Disease, the US treatment algorithm, and the European Association for the Study of Liver Disease, e antigen positive group, e antigen negative. Everybody agree that if the patients have abnormal liver tests and high viral load, they ought to be treated. The American Association for the Study of Liver Disease recommends more than 20,000 IU. Other associations recommend more than 2,000 IUs. The key thing here is if they have high viral load, abnormal liver test, they're clear-cut indication for treatment. Similarly, for E antigen negative disease, abnormal liver test, high viral load, but all three societies agree in terms of the HBV DNA level, more than 2,000 IUs or 10,000 copies, then we would recommend to consider therapy. But as you can see, there are many patients who may not fit this criteria. There are patients who may have high viral load, but normal liver test, or abnormal liver test, and low viral load. What do we do with that group of patients? So that patient would be here. So those patients who does not meet the criteria, we want to turn to assessment fibrosis. You can consider a biopsy in those patients, or consider non-invasive testing, or if they're older, if they remain E antigen positive, we might consider treatment because those patients have a higher risk of progression to liver cancer. We take into account their family history and other manifestation of hepatitis B. So those are when you individualize therapy in that group of patients. Those who have cirrhosis, with detectable HBV DNA, they ought to be treated lifelong regardless of the ALT level. Just a little bit about liver cancer screening. It's the American Association for the Study of Liver Disease recommends ultrasound every 6 months. And they start screening in Asian at age 40, Asian men at age 40, Asian women at age 50, those with cirrhosis at age 20 for African Americans from Africa. We actually practice more in line with the US treatment algorithm. We screen everyone who have chronic hepatitis B with alpha-fetoprotein and ultrasound. So with the ultrasound, you probably pick up the liver cancer early, about 70%. Addition to the alpha-fetoprotein, we might increase that a little bit, 70 to 80%. And so we usually do both every 6 months. And we start very early. Anyone who comes to my office, hepatitis B, we start liver cancer screening because we do pick up the one that have liver cancer early, especially in African American, you have to remember. And just another word about African American from Africa, we need to remember that in addition to Hep B, there may be cultural differences in terms of the environmental exposure, aflatoxin, et cetera, exposure. And even in our peanut butter here in the US, there are a certain degree of aflatoxin that is acceptable to us. And so we would need to warn our patients, especially from those areas, about the risk of liver cancer and be cognizant of environmental exposure in addition to chronic hepatitis B. Now, in terms of treatment duration, how long do we treat the patient for? E antigen positive disease, we treat until we meet the endpoint. The endpoint is going to be E antigen loss with E antigen seroconversion. We then treat them for another 12 to 24 months, and we stop therapy. If we stop therapy, we monitor the patient. Another recommendation is treat them until surface antigen loss occur. This can occur with oral agents, but it is not the majority of the time. And so this is one that we often use also. So you can use both, but once they achieve seroconversion, we can consider consolidation and then stop therapy. E antigen negative disease patient, we do not have the E antigen seroconversion to follow the patient. So oftentimes these patients will be on treatment for life. And lifelong therapy or until E antigen loss. And with oral agent, this is not a common event either. So that's why we want to emphasize to our patients that once we start therapy, the therapy will need to be lifelong and chronic therapy. We will treat it as if it is a chronic disease like high blood pressure or diabetes, which you will take a medication once a day, every day. Now, for those who have cirrhosis, we would treat indefinitely. We do not recommend to stop therapy because the risk of a flare. Those who have cirrhosis already, when they have a flare of hepatitis, they may not have enough hepatic reserve to handle a flare of hepatitis. And that's why we would recommend to continue to on the therapy. But those, if we stop therapy, we need to monitor them closely. Even if they meet endpoint to stop therapy, they can revert back, or they can develop E antigen negative chronic hepatitis B. And so we would need to monitor all those patients when we take them off therapy. So these are the results with long-term therapy with viral suppression. With entecavir, 5 years, up to 97%, if they're taking the medication, they remain virally suppressed. 99% with tenofovir. And in terms of impacts on liver cancer, in this one meta-analysis looking at different antiviral agents, lamivudine and all the other one, tenofovir and entecavir, what they've shown here is that the patients who are on treatment have a lower odd ratios of getting liver cancer. So we are reducing the risk, but we do not reduce it down to zero because there's more than there's other factors that causes liver cancer in our patient, not just the viral load. And so it does not go to zero, although it can be reduced with treatment. Now, what about cure? Is a cure possible for hepatitis B? Why can't we cure this virus like we cure hep C? First of all, it's because hep C is an RNA virus, and this virus is a DNA virus. And we'll show you that it exists in our body in several different forms. But when we talk about cure, right now we can achieve an apparent cure. That means viral suppression with undetectable viral load. And if we get a closer cure, so we can get them to lose the surface antigen. So current treatment, we can achieve this, but not in a large number. And so most of the patients will remain on therapy. And some of them, if you check cccDNA, they still have the cccDNA. A functional cure is when we try to bring the risk of death from liver disease similar to as if they have a resolved natural infection. Well, that would mean that the viral load is undetectable, surface antigen negative, they may have surface antibody, the cccDNA is undetectable, and they're off treatment. But a cure, bringing them to a total cure, whereas, as similar to they've never been infected, cccDNA undetectable, everything's negative, off treatment, this is going to be hard to achieve in the future. We might be able to achieve a functional cure, but this type of a cure will be difficult to achieve. And so in working toward a cure, we need to understand that the virus exists in our body in 3 different forms. The replicating form, which we have antiviral therapy, and we can control that form. The cccDNA remains in the nucleus, and our current treatment does not affect cccDNA. And it's a source of persistent infection, but also integrated DNA. Its genome can be integrated into our own genome, and we cannot splice it out. And not all the time that the whole viral genome will be integrated. Mostly parts of it will be integrated at different times, and that might be also another reason why we see liver cancer so high with hepatitis B in the absence of cirrhosis also, due to integration into the strategic area that can lead to cancer formation. So with the current therapy, we have some limitations. We have adequate viral suppression and normalizations of ALT. We can have some histologic response after 3 to 5 years of therapy, but we have no effect on cccDNA and no effect on integration of the HBV DNA. And so we do have a modest effect on liver cancer. So this explains a little bit about why is it that there's persistent infection that we cannot get rid of the cccDNA. So in a normal liver, your hepatocyte half-life is about 6 months. In chronic hepatitis B, it's about 3 months. So you would expect that if the patients have been on therapy for many half-life, for many years, you would expect that maybe that all the infected cell would have died off. So we would expect that after 10 to 20 half-life, most of the infected, all of them, there wouldn't be any infected cell left. But what we observed actually is that they persist even after 5 years of therapy. And that's because the cccDNA persists in the liver and causes maybe, perhaps, a low level of infection, continued infection, despite viral suppression. So when you check your HBV DNA and they're negative, they're less than 29. They're not actually 0. And so you can have ongoing low level of infection replenishing the infected hepatocytes. And that's the reason why this is going to be now the focus in the future, trying to get rid of that form of HBV. And so the goals of therapy now would be eradication of Hep B, and in addition to our previous parameters, we now possibly add the loss of cccDNA. Although now we're able to check the cccDNA, but it's not widely available yet. And so we do have treatments, and people are working on silencing cccDNA, but taking out the integration form is going to be very difficult in terms of splicing the integrated form out of our own genome. Now here is the different representation of different parts of the life cycle of the virus. So people are looking at attacking the Hep B virus at different part of its life cycle and trying to achieve a cure. Currently, we have polymerase inhibitor with the newer agents. It's a lower side effect profile, but it's still, we're only affecting the replicating form. And so people are looking at surface antigen release inhibitor. So the concept here is that the surface antigen serves as a decoy, and the virus release so much surface antigen that will bind up our surface antibody, so our immune system doesn't have a chance to do its job. So with this agent, they actually lower the amount of surface antigen, and they can see that our immune system, we do see a rise in the surface antibody. So that looks promising. People are looking at microdex, which is entry inhibitor, blocking the virus entry into the hepatocytes. There are people looking at silencing cccDNA or use particle technology, introducing interfering small RNA to try and target the cccDNA transcript. People are also looking at capsid assembly inhibiting the capsid inhibitor, and also a therapeutic vaccine, trying to stimulate our immune system to be active. And we also have toll-like receptors that will affect the immune system of the liver cell. And so there are people working at toll-like receptor agonists, trying to stimulate the immune reactivity in the cell to fight against the Hep B. So in the future, you might see that we have combination therapy. We may have a polymerase inhibitor to interfere with the replicating form, but a variety of agents attacking the Hep B at different point in its own life cycle, and hopefully with that we can improve the reduction in cccDNA. But here is also another new treatment potential target is the HBX protein, which is necessary for efficient transcription of cccDNA. So all of these are going to be future therapy, and perhaps, hopefully, in the next 7 to 10 years, we will have more of these agents coming out. These agents are now in the first phase of the investigation, and they look very promising. So in the future, I would think that we would have more than one agent to treat hepatitis B. So I know there's a lot of information that we give you, a lot of different guidelines. It can be confusing, but hopefully that I've made Hep B treatment a little bit easier for you. Thank you for your attention.
Here's a simple question. Why does this virus or hepatitis C virus just go to the liver? Why doesn't it go to the brain or infect the kidney? What is it about these viruses that
So that's a very good question, very hard question to answer is why is this virus only goes to the liver and not to other areas? It actually goes to other organ system as well at low level and also in the peripheral blood cells. And that's why when we transplant the patient, they get reinfected and we take the liver out. But they are also at low levels. And I'm not sure exactly why what is in the liver that attracts these viruses. Perhaps that we have receptors that I'm not sure exactly why, but perhaps the receptors that attracts the virus to the liver.
And a second question, in the middle you had the slide with the showing the, I can't remember now, the e-antigen development.
The natural history slide, yes.
The natural history slide. In an earlier slide, you talked about the initial viral load, and if it was high, they had the higher prevalence of hepatocellular cancer later on. Is that
right? Yes.
So why wouldn't you treat that group with the high viral load but normal ALT, AST, if they have a high risk of liver cancer?
Right. The question is, in patients who have high viral load, normal liver tests, and we know that increases the risk of liver cancer and cirrhosis, why don't we just treat that group of patients? And in our practice, those are the young Asian patients, usually 20 to 30 years old. And number one, if we were to treat that group of patients, that would be a very large amount of patient to be treated, number one. Number two, we've shown that during short-term follow-up, those patients actually have minimal changes in terms of the histology in the liver. Despite high viral load and normal ALT, they have normal histology within 5 years of follow-up. And the third point is also because our current treatment is not as effective. So the current treatment, you see that rate, I give you 90 to 95, 97, 95% after 5 years of therapy. That's in people who have chronic active hepatitis. And there are actually studies to treat the immune tolerant patients, those with normal ALT, high viral load, they respond differently. So they are not very easily suppressed with the current treatment, and because we don't have an effective treatment. So perhaps in the future, when we have a definite treatment with a possible cure that, that is cheaper for everybody, then we can consider treating everybody But at this point in time, those are the barriers to treating that group of patients. Although e-antigen positive disease patients, when they get older, we will treat. When they get older, usually they're no longer immune tolerant. They may be e-antigen positive, but the viral loads start to decrease. Remember, the immune tolerant are the one with several 100 million copies. The one who are 40 years old with 500,000 copies, normal ELT, those are no longer in the immune tolerant phase. Those patients actually may have more advanced disease. Those are the patients that I'd be worried about and consider treatment and perhaps biopsy or non-invasive assessment fibrosis in that group of patients. And actually they have shown that in men who e-antigen persists each decade after age 40, the risk of liver cancer increases. And so those are some of the reasons we would treat older patients who are e-antigen positive. Remember, immune tolerant, though we don't treat, I've used the young patient. Yes, sir.
Is there any way you can go back to the Kaiser?
Permanente study? Yeah, let's see.
I may have misunderstood what you said. While it's going, I wonder if you would agree that these are great algorithms for the patient who is not immunosuppressed. But say in the post-liver transplant patient that's gone lifelong immunosuppression, I'm not sure that applies even most of the time. We certainly have had patients that have unmeasurable vDNA, that have cleared surface antigen, who have developed surface antibody, and you take them off treatment and later they have a recurrence.
Right. So yes, so I agree with you that in your post-transplant patient who have Hep B, who we treat them and they seroconvert and they were transplanted, they need to be on antiviral therapy because we're not affecting the cccDNA. When you, especially if you give them a core positive donor, the core positive, if we biopsy those liver and assess the DNA of the virus in the liver cell, we can still find the viral DNA in the liver cell. And so we would treat those chronically. And that's the slide you're referring to. Yes. The next one? This is from the Kaiser Permanente study. The one before?
About the one
After his treatment.
Well, there was one where there was the progression to cirrhosis and the progression to hepatocellular carcinoma.
Oh yeah, that's this one. The high baseline viral load.
Okay.
Yeah.
So it was e-antigen negative patients.
And e-antigen positive,
Not surface antigen.
not surface antigen,
Right.
yes.
Okay, thank you.
So you just mentioned core positive organs and biopsying and doing DNA analysis of the...
Now, I'm just saying that the core positive donor liver still have the viral DNA in the liver cell. And that's why when you give them to a person who's never been infected with Hep B, they get Hep B.
So there's always a thought that some of these are false positive tests. Is that something to consider when we get a core positive organ, to do some type of further DNA analysis of it to truly see if the cccDNA
Is there?
in
Yeah.
there or
Yeah.
not?
So that might be something that can be done. Even in people who are immune, let's say you caught Hep B as an adult and you got over the infection, you have surface antibody, and you will have a normal life, your liver still have the virus in them. So over the years, your immune system sort of forgets about the Hep B because we're not exposed to it. We become core positive alone. But when the immune suppress, you will have reactivation. And that's what we see in the core positive patients who receive lymphoma therapy with immunosuppression. They reactivate. So I just had a lady who was referred for evaluation. Unfortunately for her, she was a little bit older, but she has pulmonary hepatitis. She's 94, but she has lymphoma, and she was core positive. But they didn't check the core, and they didn't give her prophylactic treatment. And they gave her a treatment. They now got rid of the lymphoma, but now she's, pulmonary hepatic failure from the reactivation. Yes, sir.
So when you're trying to discern whether someone is e-antigen negative or inactive, what if you biopsied someone when their ALT is normal, would they have identical histology in those two populations? Or would there?
Right. So the question is, in people who have e antigen negative, but we're trying to determine if they're inactive carrier or if they have the e antigen negative chronic hepatitis B, what do we see on the liver biopsy? In people who have e antigen negative chronic hepatitis B, they have fluctuations in viral load and fluctuations in ALT. We will see active disease. We will see inflammation and possibly fibrosis in that group of patients. So nowadays, in my practice, many patients don't want to do a liver biopsy, especially Asian patients, so that's going to be a barrier to getting a good assessment of the disease. So we resort to non-invasive testing. You can do blood test, the fibro test, and the FibroScan. I usually do both because they're two different approaches to assessing fibrosis. If they agree that the patient have a disease, then likely the patient will have disease, and instead of doing a liver biopsy. Yes, ma'am.
Are there any data supporting the effectiveness of revaccination in those patients at risk post-transplant?
Right. Are there any data supporting revaccination of those who are at risk? I'm not aware of studies specifically looking at that group of patients, but we know that the patient who post-transplant is a different animal. There's different things. There are people who never had Hep B, and then you give them a core positive, then they are at risk. But the risk is higher in the people who've never been exposed. Okay? The risk is intermediate in the people who've never been exposed, but they're immune through a vaccination. So I would recommend to vaccinate all those patients if they haven't been vaccinated. So the risk is lower than they've never been vaccinated. But the risk is lowest in those who got the infection and got over the infection. So they've been exposed and they got over it. The risk of getting reinfection and reactivation from a core positive donor would be lowest in that group. And so in anyone who receive a transplant, there are some, we don't understand actually why a small percentage of patients actually have Hep B when the donor is negative for Hep B. And they suspect that this is not common, but they suspect that maybe these people have occult hepatitis B. And so it would be wise to vaccinate all of our patients who've never been vaccinated before transplant, to try to boost up the immune system and try to bring them into the intermediate risk level.
So let me get your opinion on Hep B core positive kidneys, donor kidneys. We will transplant those patients or transplant those organs in patients that we know have been immunized and have antibody titers. The question that comes up is how much antibody titers? Some labs report just positive, others will actually say greater than 100 or so. Is the fact that you've just been immunized and have some positivity, but maybe not hugely robust, protective enough?
Right. The question is, if we give them a core positive organ and they have antibody, what about the titer? How much antibody present? Actually, that is a significant point to point out, that even if you have antibody at low titer, the patient's still at risk. So usually about above 500 is we want to get that number up to be better in terms of protection.
So how often would you give boosters to those patients and monitor them?
How often would we need to give booster after they were transplanted?
No. Prior, let's say you have somebody on the transplant list and they're immunized and their titers are low. Would you recommend?
Booster. We probably should, yes, to try and bring up their surface antibody.
One of the arguments that the nephrologists bring up is they're on dialysis, their immune
system's down, yeah.
and they can't get their titer up. And so that's an argument we get when we recommend boosters. Like, they're never going to mount. So I don't know if that's a good argument to not attempt to or not.
Well,
but
yeah.
It's a fight that we don't necessarily want to have. So.
Right. I think it's probably, it is an argument, especially, if you give them to a cirrhotic patients, their immune system is weaker. If they have renal disease, their immune system is going to be weaker. But it doesn't mean it's going to be zero. Yeah. And the vaccination is benign enough to give. And it's not really a good argument not to give it. Thank you very much for your attention.